So today is chapter 6, cartilage and bone. So you're going to see some of your first real physiology concepts today, although it's pretty lightweight as far as physiology concepts go. We shove cartilage and bone together because they're very, very interrelated. There's actually one form of bone formation. It comes from cartilage. So that's one of the reasons that they both have structures that are similar, like lacunae, and it's why we're going to consider them together. We'll do a little bit of classification and anatomy of bones, and that'll help a little bit with while we are studying bony features. Ossification, two different ways that bones form, one from cartilage, as I mentioned before, one from membranes. Different types of bones that are classified different ways will come from different styles of ossification. Homeostasis and promoting bone growth. That's going to be your sort of physiology concept for the day. We're going to learn about a couple of very, very specific cells and their very specific roles and the hormones they respond to. And that's the big concept. You're not really going to get hormones until A&P2, but you'll end up seeing hormones all of this semester, and then later on we'll explain exactly how it is that they're working. Bony markings, the linguistics of bony markings is going to help you considerably to understand the naming conventions used on that great big list of bones that you need to learn. And briefly, aging of the skeletal system, including the nature of osteoporosis, which after the homeostasis of bone growth, aging and osteoporosis make a lot of sense. Bones, cartilage, ligaments, and other supportive connective tissues make up the skeletal system. That's about all I have for you there. Cartilage, we already know that you have chondrocytes, so cells of the cartilage. And then what's that word right there, blasts? What's that going to indicate? Chondroblasts. Forming. So they're the builders. They're the builders of the cartilage. And they're going to produce the bony matrix. Once they've produced that bony matrix, they may develop into chondrocytes that are located within lacunae, and those maintain the matrix. So what we mean by matrix is the environment outside of the cell, the extracellular matrix, the stuff that the cells are engulfed in. So the tissue, if you want to say it that way. So this should look familiar. We're going to have hyaline cartilage, and on this image that's annotated in blue, so we have hyaline cartilage at the ends of long bones inside of synovial joint spaces. We'll also have it in the nose. This is hyaline cartilage of the nose, and your ribs, the costal cartilage, is also made of hyaline. Next you have fibrocartilage, and you probably remember that you will find that in intervertebral discs. You'll also find it in the pubic symphysis. They are very similar in nature. In fact, when we get to our joints lecture coming up really soon, you will learn that the intervertebral discs are also considered a symphysis joint. It just means a very a ring of fibrocartilage that makes a sort of pad. So they are both symphyses technically. Yes? Yeah, absolutely. Jenny, can you hit that? Thank you. And then elastic cartilage we know to be one of the more flexible, less rigid cartilages, and that you'll find in your ear and epiglottis. Hyaline cartilage, again coated in blue, you'll also find it in your airways, trachea, to maintain patency or openness, to keep your trachea open, which is your airway. You really don't want your airway collapsing, so you have cartilaginous rings keeping it open. So cartilage can grow in two ways. Bone can also grow in two ways. Cartilage can grow from within the cartilage or from the periphery of the cartilage. And this should really be pretty intuitive. Of course, you can grow from within or from the sides. We just have very specific terminology for it, right? So interstitial growth means growth of the interstitium, the space between cells, so from within the cartilage. So if it's in the middle of this hyaline cartilage, for example, that means these cells are dividing and creating new lacunae. Appositional growth is going to be cartilage along the periphery. We're going to have it out here, and it's going to build to expand that cartilage in one of these directions. So interstitial growth will look like this. The cell will undergo mitosis. It will expand that lacuna, and then more matrix, extracellular matrix, will develop in between these two cells until ultimately they will reside in two separate lacunae. And you can kind of see this happening histologically in here. You can see these two lacunae abutted to each other, these two lacunae abutted to each other. You can see two cells residing in this lacuna. And that will continue to expand. And again, that is interstitial growth. Whereas appositional growth, instead of being about mitosis of fully formed adult cells, matured cells, it's going to be from stem cells in the periphery. The perichondrium, and again, we can break that word down. What's peri? Around. Yep. And then chondra we know is cartilage, so around the cartilage. So this is going to expand the size of the cartilage from the periphery. Here's just another representation of the same thing we just said. This is, I think, your textbook's version of it. Okay, any question about cartilage appositional growth versus cartilage interstitial growth? Okay, something important to note about this is when we get to bone growth, you will also have an example of appositional growth of the bone, and it works in a very similar way. We will have a couple of additional concerns when we talk about appositional bone growth. So you might want to put a note on this, separating this from the concept of appositional bone growth. Appositional bone growth versus appositional cartilage growth. There is a question on your worksheet today asking you to explain appositional growth, and I didn't specify bone or cartilage, so I might have to look into some things to see which one I actually want you to focus on. All right, your bones are actually very complex and very, very much alive and very, very vascular in a living person. So by the time we get to use the bones in a laboratory setting, they are completely deceased. They're nothing but, those inorganic molecules. There's no blood supply or vascular supply. And so they have a very, very different nature, deceased versus living. Again, you know that the extracellular matrix in bones is rigid due to calcification. It's not just calcium. We're going to need some phosphate. We're going to need some organic molecules to create the structure of the bone. It's there for support, protection, movement, storage of mineral and energy reserves, and hemopoiesis. What does the prefix heme mean? Blood. Good. So does anybody want to guess what this means? Production of blood, specifically blood cells. All of the cells of the blood are actually produced in your bones. So bones can be classified by shape, and I think this is pretty intuitive. Long bones are long, short bones are short. What we mean by that is that short bones have a nearly equal length and width. So they won't all necessarily be shaped like cubes. Some of them will be round. Some of them will be a little bit oblong like this, but we still don't consider it a long bone like the femur would be a long bone. Several bones can be considered flat bones, even if they have irregular projections. The body of the scapula is very flat in nature, so we will consider that a flat bone. And then if it doesn't fit into one of these three categories, we'll call it an irregular bone. Bones of the cranium overwhelmingly tend to be flat bones. Bones of the appendages tend to be long bones. Your carpals and your tarsals of your ankles, those tend to be short bones. And then things like your vertebrae tend to be irregular, and among others as well. When we talk about long bones, we have a little bit more anatomy here, and this is absolutely anatomy. These are terms you absolutely need to know and be able to define. Hi, Raquel. The epiphysis is going to be at the very end. Epi means what? Epi, above, yeah. So it's going to be, you're going to have two epiphysis on a long bone. You're going to have a proximal epiphysis and a distal epiphysis. How do we define distal epiphysis? Yeah, so the epiphysis that's furthest away from your core body, from your axial body. The diaphysis is the shaft of a long bone, as in diameter. So this will be the diaphysis. And then between the epiphysis and the diaphysis on every long bone, you're going to have a region called the metaphysis. Part of the reason this vocabulary is significantly is the existence of the epiphyseal plate, which you may have heard of before as the growth plate. So this is going to be the region where bones grow in length, as opposed to, let's say, appositionally. And that epiphyseal plate will always be located between the epiphysis and the metaphysis. And that's a jazz hands topic. So between the metaphysis and the epiphysis, you'll have your epiphyseal plate, or your growth plate. Yes?
Can that epiphyseal plate be seen like on an X-ray or?
Absolutely. Epiphyseal plates can be seen on X-ray and a variety of imaging modalities. Absolutely. So that's actually, if any of you have kids and maybe they've broken bones, or maybe you broke a bone as a kid, if you broke your arm and your parents took you to the emergency room and they took an X-ray, and the big concern there is, did they break their growth plate? Remember? Has anybody had that experience? Did they break their growth plate? Did you break a growth plate? Yeah. Do you have any asymmetries as a result of that, or did it? Surgical, yeah, surgery to fix it. Because if you didn't have surgery to fix it, or if it was too far gone, you can have bones grow asymmetrically after that. I had a client a long time ago whose hand was permanently deflected like this because he'd fractured this growth plate right here, and this is just how he rested his hand. It was just shaped like that. So, and that caused a number of physical problems for him. There was a lot of pain associated with having his hand in that orientation while he's trying to go about his life. So that has a lot of significance. Okay. Articular cartilage, again, you have hyaline cartilage covering the epiphysis at the ends of long bones. The role of that is going to be to reduce friction and absorb shock. Within the diaphysis, you also have a medullary cavity. Now, the vocab word medulla is something you're going to see in a number of different contexts. Medulla always means it's on the inside. It's a deep structure. So within your long bones in the diaphysis, you have a medullary cavity, and that's going to be a semi-hollow, semi-cylindrical space in the diaphysis. And in adults, we're going to have yellow bone marrow. You're going to have yellow and overall red bone marrow. Red bone marrow is going to be where your blood comes from, your blood cells. Yellow bone marrow is going to store fat. We have fat in our bones. Along the periphery of your long bones, you have a periosteum So os as in bone, peri as in around. So you actually have a connective tissue membrane made of dense, irregular connective tissue. And it covers everything except where you have hyaline cartilage. So things are actually going to attach to the periosteum, not directly to the bone. So you're going to have tendons and ligaments connecting muscle to bone and bone to bone respectively. And they're not going to attach directly to the bone, they're going to attach to the periosteum. And then that periosteum will be attached to the bone via some perforating fibers. Similarly, within the medullary cavity, we'll have an endosteum, endo for within, and then osteum for bone. And these are also going to be locations for a variety of our specific blood cells, bone cells, not blood cells. You'll have osteoprogenitor cells. That's going to be a sort of stem cell. That word progenitor, what does it mean? What's that?
Like parent.
Parent, absolutely. So my mom and dad, those are my progenitors. So an osteoprogenitor cell is going to be a stem cell for bone. It's going to develop into a bone cell, such as an osteoblast or osteoclast. So we've already seen chondroblasts today. Those were cartilage-forming cells. So what's an osteoblast going to be? Bone-forming cells. And then osteoclasts are actually going to be the opposite. Does anybody want to guess what an osteoclast is going to do?
Breakdown.
Break down bone. So it's not so that you form your bone and then you have your bone and you're done. You're actually in a constant state of breaking down bone and reforming bone constantly. So here are osteoprogenitor cells, and they'll develop into osteoblasts that will form the bony matrix. And as that bony matrix is formed, they'll develop those lacunae, and they will mature into osteocytes that reside within lacunae. That should be familiar from your tissues lecture. So this is actually just one pathway for the stem cell. Osteoblasts do mature into osteocytes. And here's my good friend, the osteoclast. I think he's really cool. These cells have this thing called the ruffled border. And in order to break down bony matrix, they actually literally secrete acid onto it. That's how they break down bone. They're actually just going bleh with acid, and it's lying out on your bone. And that's going to free up that calcium as needed. If we need calcium, we're going to go to the bank of bones and get it from there. So here's a histology of an image of an osteoclast. Here's another histological image of an osteoclast showing you that awesome ruffled border. And look at those multiple nuclei in there. That is a cool cell, if I've ever seen one. Is anybody else like, yeah, that's a cool cell? Just Natasha and Raquel's into it? Good. We got some people into it. Look how cool he is. I think of him as Cookie Monster. When I'm trying to keep those cells straight, osteoclast for Cookie Monster, going and breaking down that bone, and just like Cookie Monster eats cookies. And then there's crumbs everywhere because he's a puppet and we've got crumbs everywhere. Now again, it's not just calcium in your bones. You're going to combine calcium and phosphate and some hydroxyl groups, don't worry about hydroxyl just yet, into something that we call hydroxyapatite. It's a really fun vocab word. A lot of standardized exams really like to focus on hydroxyapatite for some reason. I know the MCAT does. I don't know if the NCLEX does. I would say that's a worthwhile vocab word for you long term. So again, that's just the way that we store calcium and phosphate and hydroxide into our bones. That's just the organic compound that we form out of these inorganic substances. Actually, it's all inorganic. Ignore that I said organic just then. Some organic chemist just rolled over in their grave and is mad at me now. Aside from hydroxyapatite, you also have quite a bit of collagen fibers in your bone, and structurally they are both very, very important. You need a very healthy mix of collagen and hydroxyapatite to create the strength and flexibility of a living bone. So obviously if a bone's deceased, you can kind of, they're pretty easy to break if they're real bones. We only have plastic bones, so you'll never know quite how easy they are to break, at least at this program. It turns out it's really easy to break deceased bone because the collagen is organic and it has dissolved away in the decomposition process. So if you're lacking collagen, that means your bones will easily break. On the other hand, if you're lacking calcium, your bones will easily bend. So you need a healthy mix of the two. You need a bone that is flexible enough to respond to minor traumas without breaking, but rigid enough to actually support you without making you floppy. Yeah, no, those are both disease states that can absolutely happen. And yes, they are gross, I agree. So you have both compact and spongy bone. I'm actually going to skip to this slide and then go back. Compact bone is what we were generally looking at histologically in our tissues lecture. Compact bone looks like those tree trunks all stacked together with some more cells and more bone tissue in between the tree trunks. Spongy bone's a little bit different. It's going to be made out of trabeculae. You can still have some circumferential rings in spongy bone like you do here. I think this illustration accurately portrays what's going on. You still have osteocytes, they're still in lacunae. You just don't have the sort of organized tree trunks structure. Flat bones will have both compact and spongy bones. Or spongy bone, as will long bones, every other type of bone. They all have this organization. The difference with flat bones is that you have a sponge sandwich sort of thing. So the compact bone is going to be on the superficial and on the deep portion. And the spongy bone is going to be in between, just sandwiched all the way through that flat bone. Any questions before I move on to the Haversian system? Because it's its own thing. We're about to get into a pretty big concept. Yes?
Just one. So something like rickets would be just like lack of calcium?
So rickets, I believe, was a lack of vitamin D, which is a necessary substance for calcium deposition into bone, if I recall correctly. Yeah, absolutely. All right, Haversian system. There's a lot of vocab going on here, but it's just to describe this very specific organization. Each of those tree trunks is known as an osteon. So every little circumferential lamellae organization that looks like you cut down a tree and you're looking on it head on, that is an osteon. So an osteon is defined as it's a cylindrical structure. They run parallel to the diaphysis. And again, we're in a long bone right now for this organization. They run parallel to the diaphysis. They run in the direction of force. So if you're standing up and you're putting pressure on your femur, then this is the direction of that force, more or less, right? That's the direction your osteons are running. That cylindrical structure is going to give you that strength of that structure. In the middle of each osteon, you will have a central canal. So the dead middle of that tree trunk is going to have a canal in it. It's the central canal. And that's going to be for blood vessels, also nerves. So a major nerve, artery, and vein. One pattern we're going to see long term is that nerves, arteries, and veins travel together. You're pretty much always going to see a set of three coming in through any hole that you might have, not every single time, but very typically. There's going to be a nerve, an artery, and a vein for it. We're also going to have, I mentioned the concentric lamellae, so every ring of the tree trunk is a concentric lamella. Now if we zoom in on this tree trunk, here's the osteon. This is just a sort of pie slice of that osteon. Here's the central canal. This is a concentric lamellus. This is a, or lamellus? This is a concentric lamellus. This is a concentric lamellus. Not sure if I'm saying that right. There is an osteocyte within a lacuna. There is an osteocyte within a lacuna. There is an osteocyte with a lacuna. And each of these osteocytes have cellular projections that perforate, that go through those concentric lamellae and can communicate with other osteocytes through those cellular projections. So they're in touch. And those channels that go through the concentric lamellae are known as canaliculi. So far so good on vocab? It's just a lot of terminology. A couple of more things you're also going to have, in addition to central canals with nerves, arteries, and veins, you're going to have communication between two osteons via perforating canals, and the old school term for this is Volkmann's canals. Now we focused on the osteons that are circumferential lamellae. These are complete rings stacked, but we also have cells and lamellae between these spaces, and we call those interstitial lamellae. They don't have central canals. They may get their blood supply a little bit more peripherally than that. They'll be in the spaces between, so perforating canals will probably help feed them. They're actually the remains of old osteons. I mentioned earlier that we have a process of continuously breaking down bone and laying new bone down. So once upon a time these were complete osteons, but we broke them down for calcium and we laid new osteons down over them. So that's pretty cool, right? Is anyone else? No? Okay. And again, spongy bone does not have true osteons. The blood supply, that's a great sound. The blood supply actually goes through the holes of this sort of spongy texture here. So they'll get their nutrition and oxygen that way instead of having central canals or perforating canals. You still have lamellae, you still have not osteons, you still have osteocytes in lacuna, you still have canaliculi. And that illustrated right there is an osteoclast along the periphery. Okay, vocab quiz, real quick. This blood vessel is traveling within a central canal. This blood vessel is traveling within a perforating canal. This, what type of cell is this? Osteocyte. And what is it residing within? And how is it communicating with other osteocytes? Canaliculi. Good. Let's see, what else? What is this structure called that's not part of a complete osteon? Interstitial lamellae. Good. What type of bone is being illustrated here? Spongy. And what type of bone is being illustrated here? Compact. What's being illustrated right here that's being peeled away? What's that outer membrane of bone called? Periosteum. And you can see the perforating fibers being illustrated there too. Good. Okay. Ossification, 2 options. You can develop new bone within a membrane, or you can develop new bone inside of, what's that? Chondrule? Chondro means cartilage. Most of your flat bones, all of your flat bones, I should say, ossify via intramembranous ossification. So I mentioned earlier, many of your flat bones, the examples would be bones of the cranium, are all considered flat bones. And you can even prove to yourself that this happens intramembrously, or via intramembranous ossification. So if you've ever held a newborn baby, you know about fontanelles. What's a fontanelle? The soft spot, right? So it's where the flat bones of the skull have not completely formed or grown together yet. There's just a membrane, and it's very delicate, right? So that is where that infant is going to continue intramembranous ossification until those soft spots close. And there's multiples. There's an anterior, posterior, squamous. So that is how we can prove to ourselves that intramembranous ossification happens. And it happens relatively simply. You're going to have an ossification center form within a membrane. And those osteoblasts will start laying down bony matrix, and some of them will differentiate into osteocytes, and those are going to start forming, they have the lacunae, they have the canaliculi. It's not quite lamellated just yet. It's going to form into a premature form of bone called woven bone. Again, we have osteocytes within lacunae. They're maintaining the extracellular matrix. They're just not very well organized at this stage of woven bone. But gradually they're going to form lamellar bone, and it's going to replace woven bone. And ultimately we're going to end up with the compact and spongy bone arrangement that we are used to. And that's really it. You don't need to go into more detail than that. Know which cells are involved. We're going to have osteoblasts forming the matrix, osteocytes maintaining it. And recall that we are replacing this woven bone ultimately with lamellar and spongy bone. So we do have a constant remodeling process, which means osteoclasts, our cookie monsters, are breaking this down continuously and reorganizing it as it develops. Questions about intramembranous ossification? Then we will move on to endochondral ossification. Now there's going to be a couple of different slides that address endochondral ossification in a couple of different ways. This slide is going to tell you the steps of endochondral ossification, and this slide and the next few slides are going to give you the histology of endochondral ossification. So they're both describing the same process. What they're both describing is, this one's starting from a fetal development. So before you're born, most of your bones are cartilage. That's actually the first way that bones form in a developing fetus, is as cartilage, not as some hydroxyapatite structural thing. So it's bad for pregnant women to get CTs and x-rays, so we don't have very many, which is a good thing, CTs and x-rays. If we get a CT of a developing fetus, it's probably by accident, but if we were to look at that, we would see very little ossification. We would see a density on the CT scan that indicates cartilage in those locations. So the fetal hyaline cartilage model develops. It's almost like a template. So if this was, your femur, as a fetus, your femur was just going to develop sort of as a cylinder shape, and it was going to form from there. So that's the fetal hyaline cartilage model. The cartilage is going to begin to calcify. There's going to be a periosteal bone collar, and this is what they mean by periosteal bone collar. So it sort of develops a cortical or superficial bone collar, while ossification happens within the diaphysis first. Primary ossification center in the diaphysis with secondary ossification centers in the epiphysis. This is why we're ultimately going to form a growth plate. because we're going to have ossification happening within the epiphysis and within the diaphysis, and it's going to slowly close that gap between the diaphysis and the epiphysis as we grow and develop. And throughout childhood, you maintain some of that cartilage. That is the growth plate. That is the definition of the growth plate. So as young, like as a preteen, as in early teenage years, depending on when you stopped growing, you were still putting your weight on cartilage. And that is normal. Gradually, bone replaces cartilage except for the articular cartilage at the epiphyseal plates. And then eventually, in adulthood, the epiphyseal plates ossify and form epiphyseal lines. And that's actually some vocab you're going to see with some bony features. You're going to find some epiphyseal lines, like, for example, the neck of the femur. The anatomical neck of the femur is an epiphyseal line. Or not femur. Humerus is what I'm thinking of right now. Sorry. So that's endochondral ossification. Histologically, it looks like this. You have 5 zones where we go from our sort of standard hyaline cartilage appearance. And then that cartilage proliferates. And it undergoes a lot of mitosis, and it does so quickly that these lacunae stack on top of each other. They look like stacks of coins almost. That cartilage becomes hypertrophic. It stops decreasing in number and starts decreasing in size instead. Then it begins to calcify, and those chondrocytes begin to die off. And as it ossifies, it becomes that immature woven bone that will ultimately mature into cortical and spongy bone. And that is described specifically in these slides as well. In ossification, we do need to develop capillaries. We do need invasion of osteoprogenitor cells so that that osteoprogenitor cell can become an osteoblast, which can form more calcium extracellular matrix, hydroxyapatite, and those can mature into osteocytes and develop those lacunae and that osteon structure. Okay, even though it's not quite been an hour, I feel like that's a really good stopping point.